Yes.
Okay. Okay, cool. Let me go back to sharing my screen. Can you tell that I'm a millennial? No, you can't. Okay, cool. So I'm just going to go through the first part of the PowerPoint. So I'm not sure if any of you had time to go through it at all, but we're just going to go through some of the important parts of it. The first part is like basics about giving medication and sort of how medication supervision works. And then the second part is a little bit more about the specific medications, like some of the most common medications you'll see at the programs and some of the most common medical concerns that clients have. So basically, there's three main ways that clients can get medication. So these are having them administered by licensed personnel, having unlicensed personnel who are trained, like supervised self-administration of the medication, and then the clients just taking the medications themselves. And most of what we're having at Gilead is the supervised self-administration of medications. So that's primarily what we're going to be talking about. So in the supervised self-administration, the clients are giving the they're taking the medications themselves, but a staff member is supervising them to make sure they're actually taking them, seeing if they need any help, and just kind of monitoring them after they take the medication. And for the most part, this is commonly oral medication. So, and also like some topical medications and inhalers. So certain medications staff can supervise and certain medications staff can't. So you'll never be asked to supervise like clients giving themselves like a rectal medication, a vaginal medication, anything like that. It's for the most part the oral medications and some topical and a lot of inhalers. And then with like injections, for the most part, nurses are giving injections for clients who need them, with the exception of some clients with diabetes will give themselves insulin injections, and that might be something that you would be supervising with, but less common. So when we'll get more into the nitty gritty of the 5 rights, but this is just a little basic slide on the 5 rights, which are like the most important things that you're going to check when you're giving medication. So even if you've known a client for 10 years, every time you give them a medication, you're going to make sure you're checking all of these. So checking that it's the right medication, the right patient, the right dose, the right route, and the right time. And even though these seem kind of basic and silly, they are the most common reason that someone gets a medication error is that they missed one of these things. So it's good to really keep these in your mind. So just some basics in here about medication administration. It's helpful to definitely know why clients are getting certain medications. You don't have to know like all the complex pharmacology of it, but just knowing like, oh, okay, like this is for their schizophrenia, or like this is for their constipation, just so you can kind of have that in your mind, and also like common side effects, so that if you're noticing certain things in your clients, you might know when to call the provider. No medication is harmless. They'll all have specific effects. And there's a bunch of different reasons for clients being on different medications. And it's good to know that no medication is harmless. And so it's really important that, again, you're making sure people are getting their medications in the amount that they're supposed to, when they're supposed to, and that you're aware if they're, obtaining other like drugs or medications, because medication interactions can be pretty dangerous. So before you supervise someone taking medications, equally good with COVID, making sure that you're washing your hands always. And like I said, in terms of like mixing medications, another big issue that can happen is an overdose of medications. So this might be accidental, or it might be on purpose. And this might be with prescription medications, and also commonly with over-the-counter medications or other drugs. So definitely making sure that you are monitoring clients and making sure they don't have like over-the-counter medications. Like all medications, even supplements and stuff, should be like everything should go through the pharmacy. So clients shouldn't just have like their own bottles of Tylenol in their room, since this is, even medications like Tylenol or Advil are commonly used in possible like intentional overdoses. So if, like, obviously if someone has overdosed on a medication and you're aware, you'll definitely want to call 911 and call your AOC and managers. But these are some symptoms, but like trouble breathing, vomiting, lots of things, but these can, indicate other things as well. But, and they also might not have any symptoms if they have just overdosed on a medication. So these might happen or they might not, but just making sure you're kind of paying attention to what's going on around you. And this is also the poison control number. So that can be a resource if someone has ingested a household substance, but for the most part, you're gonna want to go through your AOC who can decide what to do, or call 911 if there's a clear medical emergency. So there's a ton of policies that Gilead has about the storage and supervision of medication. So this is just sort of an overview, as I'm sure you are all aware. And so in terms of the medication storage in the programs, there in the group homes, there's one staff member who will have the medication cabinet key every day. And this is like signed out to the next person when they arrive. So that person is sort of in charge of making sure that those medications are locked for the shift, and ensuring that if someone needs to get in to get the medications, that they can, and then it's locked up again. And also that the medications, the controlled medications, are counted, and the controlled medications are in a double lock system. So they are typically kept separate from the regular medications. And the medication cabinet keys stay in the program. So if someone needs to leave the program, like the person with the keys, they'll have to transfer the keys to another staff member who's there.
That's right.
Okay, and Maya, are you gonna do the 5 rights?
Yeah, great. So now we're going to sort of dive into the 5 rights, as this is sort of like the foundation for supervising medication self-administration. So first we have the right person. So this is super important, making sure that the person on the bottle is the person in front of you, making sure often we're not working with bottles, we're working with dispel packs. I'm assuming most of you have seen them, and they sort of like say for each day and each time. And so there is a client name on the top of that, as well as each bubble pack has that client's name. So it's checking and making sure that that bubble pack all matches, and then that matches with the MAR, and that matches with the you.
Yeah, walking across the table.
Allie,
I probably saw the spur just moving across the screen.
Darcy, can you mute yourself?
Push down the table.
Perfect. Thank you, Allie. And so then the second one is, and just one more thing about right person, just making sure that you're only taking one box out at a time. So generally every client has their own box or their own folder, and making sure just using that person's box in that moment. Second is right drug. So making sure that if the Dispel says Depakote, that their MAR says Depakote for that time. And really checking that across. Often I ask clients, I hand them their Dispel and I say, is this you? Is it right? Like, is this your name? And also making sure I know that first, right? Like knowing the clients, but also like it's for me, it feels empowering to them, right? That they can have some sort of role in this medication administration, right? Like this is their self-administration. So is this you? And are these your right meds? And they might not know, but just having some sort of conversation so that they can be part of that. So yeah, just checking and making sure it's the right drug. Next now. So just some common lookalikes. These are a bunch. I will say the one that I'm going to point out is Clonazepam versus Clozaril. Clozaril also can be called Clozapine. These are commonly mixed, and also some clients are taking both, right? So making sure that we're matching the right med for that person, and we're making sure it's the right dose, right? Like a dose for Clozapine is different than a dose for Clonazepam, and making sure that those match. And just some common abbreviations. We have a rule of thumb that as like staff at Gilead, we do not write abbreviations, but the pharmacy does. So we need to be able to take what the pharmacy gives us. So right, like they might say trazodone 50 milligrams, TID, or not TID, BID, PO. And we need to be able to know, okay, like that means that this person's going to take it twice a day and it's going to be by mouth, right? PO is by mouth and BID is twice a day. So just making sure that we know these and we can sort of translate them. However, as a rule, we're not going to write abbreviations, as this minimizes error, right? The more abbreviations, the more confusion that can be created, but we need to know like, okay, HS means bedtime. So just review these and sort of familiarize. Okay, so right dose. So right dose should always be reviewed prior to the client taking medication, right? So we take that box out for that client, say so-and-so. So, okay, so-and-so comes to the door. I get their box. I make sure that their box says so-and-so on it. I then open up that box. I take the Dispel out. I'm checking name. Okay, same person. I'm checking drug, right drug. Okay, now I need to check right dose. In these group homes and in a lot of these programs, medication dosages change frequently. And so medication doses can change in two ways. One, the milligrams can change, right? Someone can go from trazodone 25 milligrams to 50 milligrams, and maybe they're receiving a different pill, okay? So the dose, the amount in that pill is changing. It can also change with the number of pills, right? So someone can take 2 pills instead of 1. And so making sure that in both those ways, it's the right dose. That's one way in which we do have mistakes, right? Because it's easy to quickly see, oh, this looks like the right med, right? Looks like the same thing as normal. And oh, maybe their prescription changed, but we didn't update it, right? So that's an important way that we can minimize error. Right time. So we give meds, well, generally in most of the programs, there's 4 time frames throughout the day. So like AM, noon, like evening and bedtime. And just making sure that it's the right one. If someone misses their medication, say they miss their noon, we don't want to keep it on that dispel. We want to put it in the refused bin because that creates confusion. Then we have an extra bubble pack floating around, and we can't give a noon med at a different time, right? If they skip their noon meds, it can't be given to them after noon, like after that time frame. So really making sure that we're taking it off that dispel and putting it in the refusal bin. So that way, when evening comes around, it's just that evening dispel and we don't have any sort of confusion. These are just a review of what the timeframes are. So AM is 7 a.m. to 11 a.m., noon 11 to 1, PM is 3 to 5, and HS is 7 to 11, and then PRN is as needed. So the key to this is that basically check with your program. Some programs have different timeframes, and also some clients have different timeframes, right? So there can be one client who maybe they wake up late, right? And we've talked with their prescriber and come up with a team plan that they can receive their AM meds until 1. Okay, that's been approved, right? Like we can't change that time frame, but a provider and prescriber can. And so then we need to make sure that that's documented everywhere. Okay, this person gets a different time frame. Okay, so just really being super aware of time frames. I will also say if you see that, oh my gosh, this client misses their morning med every day, like that's a way in which we can also bring it to the prescriber and say, hey, this person misses their med every morning. Like what can we do differently? How can we work together as a team to make sure that they're successful? Right route. Okay, so the big thing about right route is, so one is that sometimes people think this is funny, like how would someone get the wrong route, right? Like they look how they should go, right? But the thing is not always. Like sometimes the medication for a nebulizer comes in sort of a capsule form, and we cannot ingest those orally. They need to go into a nebulizer. So we need to really be checking like, okay, this is where this goes. Another big thing is, so PO is orally, but we could also be giving a medication sublingually, which means it needs to go under their tongue, or buccally, which means it needs to be held in their cheek, right? And so really checking those, because the medication won't work if it's not dissolved under the tongue, and that's really important. So just some common routes to review. So orally, buccally is again in that cheek pocket, sublingually under the tongue, and you wait till it dissolves. Ear drops. Next slide. Dermal patches. So those are those patches that they often, I think, we're handling nicotine patches, right? So you just like stick them often your rotating sites. So that's a good prompt for clients, like make sure you're choosing a new site today. Inhalation, so using inhalers. Nasally, so it like goes up someone's nose, making sure that they're doing that correctly. All other forms of administration are not really being supervised for self-administration, as Ali talked about earlier, except for sort of like some clients are receiving injectable insulin. I'm going to say for all of these, this is all supervised self-administration. So we're not holding an inhaler up to anyone's mouth. We're not doing any injections, right? Like we are guiding the client and doing it for themselves, which often means reminding, right? Like, oh, make sure you breathe in for this number of seconds. Make sure your dermal patch is all the way down. Like those types of prompts, like, oh, don't cut the dermal patch. Like that's not what the prescription says. Like sort of like really prompting, but we're not putting a patch on someone. So just making sure we all know that different clarification. Okay, so in a nutshell, so a client comes to the door. So-and-so, you can ask them to go get water if they don't have water, right? We want to make sure that they're prepared to take their oral medication and to wash their hands. We wash our hands. We can get the MAR out, and we get their medication box out of the locked storage. We can match their dispel to the MAR. We are going to check every right. So all 5 rights between the dispel and the MAR. So you like hold them next to each other, you go across, making sure that every medication is included. We're not missing any, there isn't any extra medications. Then the key is, so they come in these dispels, right? You can have the client open them. You can open them, whatever the client prefers. Often I'll hand it to the client. I'll say, okay, this is you. They'll say, yep. I'm like, these are your medications? Yep. Do you want to open it or do you want me to open it? Sometimes they want to open it themselves. That's great. Sometimes I open it and put it in a container, up to them. I hand it to them. They take their medications. The key is to stay with them when they're taking their medications, right? Some of our clients might not realize if all of the meds go in, or maybe there's a med stuck at the bottom of their little cup. Maybe they drop one on the ground. So just really making sure that you're there with them. Yeah. And then after all of that, so after we've checked them against the MAR, we've given the client the meds, then we go back to the MAR and initial. We don't initial in the MAR and document that the client has taken the medication until the client has taken the medication. And if the client misses the med, maybe we can't find the client, they went out for the day and didn't plan on coming back for their medications, which generally we try to make sure that that doesn't happen, but sometimes things happen. We're going to mark missed, and which we'll explain later. And we put that, or maybe they just don't want it. Then we take that dispel and we put it in our refusal bin. So documentation. So the key to this is that, so right, like physicians and nurse practitioners prescribe these medications, and we get new MARs every month. So at the beginning of the month, the MAR is up to date. However, medication prescriptions change throughout the month. And so when a prescription changes, we need to make sure that's transcribed correctly in the MAR. So any trained unlicensed staff or a nurse can transcribe it in, which we'll show you on the next slide. Allie, can you? So at the bottom, you'll see how to write in a new prescription. So the key to writing in a new prescription is we need all 5 rights. Now, one thing you're going to say is there's no client identifier, which is true. We don't normally put that in the box because the client's name is all over the sheet. So that's the only thing that doesn't actually end up in that box, but everything else does. But so we're not going to get this nicely written sentence. What we're probably going to get is Lexapro 10 milligram, 1 tab, BID, PO. And we need to transcribe that correctly so that that client gets the right meds. The other thing is that we have to write in what time they're going to get it. So, they're going to get it at 8 a.m. and 8 p.m. And that matches the dispel and it matches the order. And now it matches the MAR. Okay, so let me see. So this is just really, we want to emphasize that we're not going to initial in the MAR until the person has received their medication. We don't want to do it before. We really want to make sure that they've fully taken their medication, because if they haven't, we're gonna document differently. And just another note on this one is for PRN medications. So those as needed medications are called PRNs. And we're going to initial, and we're also going to include a time. And this is because sometimes folks can take maybe a PRN twice a day, but they need to be 4 hours apart. And so we need to be able to say, okay, this person took it at noon, and the next time that they can take it is 4 p.m. So just really adding that into that documentation. Please do not erase in the MAR or use whiteout or any sort of, it's considered like a legal document, right? Like this could be used to like demonstrate that how frequently this person's taking meds. So if there is an error, just single line through an initial saying that was you and that you did that, just so that we have sort of like a track. Once we have whiteout, we sort of ruin the integrity of the document. So for control meds, so control meds are generally locked separately. Now this does differ by program, as like a PRN control versus like a control that someone gets every day at noon. So a standing order might be processed differently depending on the group home. Sometimes they're in their like daily medication dispel. Sometimes they're outside of it. So just being aware of that as you move through different programs. But generally, if they're in a separate location, so like say the PRNs are in their own box, right? The PRN controls, you need to sign in 2 locations. So you need to do the MAR, and you also need to sign on the control count sheet, because the control count sheet basically tells us how many controls we have in the building at that time. And every time one gets taken out, we like literally have a running count. So 10, 9, 8, 7, right? Like it's like truly a full running count with someone's signature saying who took it out, when the client received it, and so on. And that's really important. And that is also what we use to do control counts on every shift. So sometimes a client might have a documented contraindication for a medication. For example, so-and-so can't take this med if they're intoxicated with alcohol, right? Because they might have a increased risk of something. Okay, so then we as unlicensed personnel are going to be part of that process of figuring that out. However, generally, that if that is a case, like if there's a case in which someone doesn't receive a med for a certain contraindication, it is very thoroughly documented everywhere. Otherwise, if we don't have that documentation, which is coming from a provider, then we can't really withhold a med. If for some reason you're concerned about a client, call AOC, right? That's the go-to, because AOC can call the on-call MD and sort of troubleshoot with everyone to make sure, basically the gold standards, we want to make sure that our clients are safe while they're taking their medications and taking them when they need them. Okay, so make sure that we're putting our initials in the appropriate box and circling our initials if it's refused. So basically, the MAR, there's like a day for each date and each medication. And so if the person takes the medication, we just put our initials. So I would put MCS, I supervise this self-administration. Okay, so-and-so decides that, you know what, I don't want my meds today. I'm not feeling, my stomach hurts and I don't want them. Okay, so I might have a small conversation with them, like why, let's have a conversation about why they might not want to take their meds, but they don't want to take their meds today and this is why. Okay, cool. So I'm going to put that medication in the refusal bin, and then I'm going to go to the MAR, and I'm going to put my initials and I'm going to circle my initials, and then I'm going to flip over the sheet, and on the back there's all these lines where you can add sort of like extra documentation. And so I'm going to write my initials and I'm going to say the date, and I'm going to say the quote from the client about why they didn't want to take their meds that day. And that's so that we can have sort of a running track, because we want to, if there's a reason, say their stomach hurts, okay, well, if their stomach hurts because they're taking this medication, we want the prescriber to know that, right? That's an important sort of, we can have an intervention around that, or the prescriber can. So big things from this slide, you must include your initials or it doesn't count. And then please use a pen, no pencils, just no whiteout and no pencils. And make sure that we're not using abbreviations, and as best you can, try to make it legible and neat. I know it's small, they're small boxes, but yeah, that'd be great. Make sure that there's no blanks. If you find a blank in the MAR, like say from the day before, say you're giving news and the day before is blank, notify the program director or manager, as basically if there's blanks, we're increasing error, right? Like all of a sudden someone thinks that it's this day and they start initialing on the wrong day. And so we can increase errors in that way. So we just want to make sure to mitigate error that we're documenting, and we're also notifying folks. So all meds are stored in locked locations. Be familiar in different group homes and different programs, they're in different locations. So just make sure you know where. And just like say you got so-and-so's med out for 11 and they decided that they don't want to take their med yet. They want to wait till 12:30. Cool. Okay. Don't leave the medication out, right? Like we want to put the medication back in their box. So that way we're mitigating error, right? Like next person comes along, we want to make sure that person doesn't get those meds, right? Like, yeah. This is just making sure we know where medications are stored. So some medications need to be refrigerated. For example, insulin often needs to be refrigerated. So just making sure we know what meds those are and making sure that they are constantly going back in the refrigerator, as they, some of them can mean that we can't use them. So medication errors often come from when the 5 rights don't sort of happen, right? So wrong person, wrong medication, wrong dosage, wrong time, wrong route. So we really want to check each of these things every medication pass. There's lots of checks and balances built into the system, and at the same time, those checks and balances are sort of dependent on our ability to sort of like do this every time. It can be weird to verify someone's name every time, but you know what? Like that's important to keep our clients safe. So just making sure we're doing that. And I think the number one thing for me is try to minimize the distractions in the environment. It's really hard sometimes in a group home, right? The phones are ringing, so-and-so needs things, so-and-so's here for meds, and just really asking folks to like have your space and your time to take out meds and look in the MAR and really make sure that there's really minimizes errors. This is just make sure that we're verifying orders. I think sometimes transcribing is really hard, and just making sure that everything is verified, the orders are correct. And yeah, and also just looking at the integrity of the pills, like they come weekly, so generally we're pretty okay, but just making sure, like if a pill looks funky or has like cracked or something, like we send that back to the pharmacy. We call AOC and we replace it. Verifying client identity every time. I've already said this, but just, yeah, asking every time. Okay, you're so-and-so, great, awesome, here's your med. So we also give over-the-counter medications, right? Like, as Ali said, we don't really often have clients we never have clients have over-the-counter medications in their rooms, right? Like if they need Tylenol, they can come to the door and like we have Tylenol. So the two things about this is in the MAR, there's a sheet that says what over-the-counter medications their basically like primary care provider is okay with them having, right? Some people can't have Tylenol because there's contraindications, or they can't have Advil. So just making sure of that. It says it in the MAR pretty clearly. So making sure that they can, and then documenting, just like we document every other medication. We have like most programs have like a stack of like over-the-counter medications, and sort of making sure that like we're following the instructions on the pill bottle, and we're documenting, again, initials and time, right? That's an important thing with over-the-counter PRNs. Again, avoiding abbreviations, avoiding distractions. And if you don't know how to use a device, say you've never used an inhaler before, ask around. And let's make sure that like we want all of our staff to sort of understand how the devices work. Like nebulizers, like we can troubleshoot and we can have a conversation about how they work so that you all know. Great, and now I'm gonna pass it on to Ali to talk about common medications and medical conditions.
Okay, so I'm just going to go through some of the most common medications. So this is a pretty common one. So antipsychotic medications, clients are on them mostly to treat schizophrenias and related disorders that involve psychosis. So these are generally in either pills or in long-acting injections. So clients might be on one or the other or both. And common side effects of these are sedation, constipation, dry mouth, weight gain, nausea, vomiting, and low white blood cell count, just with Clozaril, which is why people on Clozaril have to get their blood drawn once a month to make sure that nothing funky is happening with their white blood cells. And another common side effect is like movement disorders, which is extrapyramidal symptoms. And clients might also be on medications to manage these side effects. So a lot of people are on like laxative type medications to treat this constipation. So there's two main categories of antipsychotic medications, basically the old ones and the new ones. So clients at Gilead are on all of these for the most part, some old and new. So like some of the old ones would be like Haldol or Thorazine, and the new ones are like Abilify or Invega. And I just wrote down the generic and brand names. So like haloperidol is the generic, whereas Haldol is the brand name, because it can be easy to be like, oh, this medication's different, but in reality, it's just some places prescribers will write the brand name and some they'll write the generic. So just making sure you know like they're the same thing. Extrapyramidal symptoms, or EPS, these are side effects of antipsychotic medications. These are like the movement disorders. So there's the tardive dyskinesia, which is like the lip smacking or like tongue moving, these little movements, and akathisia, which is feeling like super restless, like you're going to jump out of your skin, something called dystonia, which is like severe muscle contractions or twisting, and then Parkinsonism, which is basically just looks like you have Parkinson's disease. You might get like tremors or like shuffling walk of someone who has Parkinson's. And these are known possible side effects, but they're something that you definitely want to report. So definitely, if you notice a client is developing something like this, talk to someone so that the provider can find out, because they might want to switch someone off of these medications. And these are more common with the older antipsychotics like the Haldol versus the newer ones like Abilify. And one for the newer antipsychotics they have less of a risk of the movement disorders, but they have more of the metabolic side effects. So what that means is it can make someone more likely to develop like type 2 diabetes and heart problems, because it can increase cholesterol, increase weight, increase blood pressure. So that's one reason that so many clients struggle with these sorts of health problems, because these medications can be pretty hard on the body in that respect. Polydipsia, you'll see this word around. This is just a fancy word for excessive thirst. So it's common in clients who have schizophrenia, and also just from those taking antipsychotic medications. So this like seems kind of harmless, like we all should drink more water, but this is can be dangerous because it can decrease someone's sodium level in their blood. And we need sodium to function normally. So if someone drinks so much that it can sort of dilute their blood, and they can get really confused and dizzy, and it can lead to seizures. So just being aware if there are clients in the program you're working that struggle with this, and they might be on fluid restriction, and you might need to kind of keep tabs on how much they're drinking and how they're feeling. So neuroleptic malignant syndrome, this is a sort of severe reaction to an antipsychotic medication. So it can cause symptoms like very high temperature, muscle rigidity, altered mental status, high blood pressure, sweating. So this is a reason that someone would have to go to the hospital. So just kind of being aware of what is normal for your clients, and communicating with them and making sure they know to come talk to you if they suddenly start feeling very unwell. Antidepressant medications. So a lot of clients are on these as well, used for lots of things like depression, anxiety, OCD. One big thing about these is that they don't kick in immediately. So if someone starts an antidepressant, they may not feel better for a few weeks. And there are also some side effects associated with these, like stomach upset, headache, sedation. These are a bunch of antidepressants. There's a few different types, like SSRIs, SNRIs. Some of the most common ones are like Prozac, Lexapro, Paxil, Zoloft, Effexor. These are pretty common. You'll likely see a lot of people taking these. Serotonin syndrome. This is another sort of emergency reaction that can occur. Generally, if someone is taking a bunch of medications that affect their serotonin, or if they're taking those antidepressants that affect serotonin, and also taking certain supplements or drugs. So that's another reason why it's good to make sure that no one is like has a secret supplement stash, because it can have real effects on their prescription medications. Mood stabilizers. So these are another common class of medications. A lot of these are also seizure meds. So like Depakote or Lamictal are used for seizures, but also used for managing mood in people with bipolar disorder or similar disorders. And another one of these is lithium. And lithium is can work super well for a lot of people, but it is something that you need to kind of keep tabs on, because it can be dangerous if someone has too much or too little lithium in their body. It needs to kind of be at like a steady state. Lithium can be affected if someone is really dehydrated or losing a lot of water. It can cause the lithium to build up to a toxic level. So in clients who are taking lithium, just making sure you're monitoring them and reporting if they suddenly start feeling unwell, if they're suddenly vomiting a lot, or they're extra dizzy or blurry vision, or anything like that. Just making sure you're kind of aware of that. Anti-anxiety medications. So commonly there's a lot of people at Gilead who are taking like benzodiazepine. So this would be like Xanax, Clonazepam, Lorazepam. These are like short-term relief. So they're not super good at managing long-term symptoms, but they are good for kind of calming someone down in the moment. One reason that they're not super good long-term is because it is a controlled substance, and there's a lot of potential for someone to get dependent on these. And also these can be dangerous if they're combined with other sedatives, like in someone who's taking opioids or alcohol. It can like sedate someone to a dangerous level. There are also non-controlled anxiety options. So sometimes people will be on SSRIs for anxiety. They might be taking hydroxyzine or buspirone. Also, sometimes people will take medications specifically for sleep. So like trazodone, melatonin, those are common ones. And then some of the other like controlled ones that we talked about. These are some common medications for substance use disorders. So if someone has an alcohol use disorder, they may be taking naltrexone, which can be a pill or an injection called Vivitrol. And there's also Antabuse, which is the one that you take and it makes you sick if you have a sip of alcohol. And acamprosate, which is another one. And then for clients with opioid use disorders, people might be taking Suboxone or buprenorphine. And also for anyone who uses opioids, they should have a prescription for Naloxone or Narcan, which is the emergency intranasal medication that can reverse an overdose. Lots of clients at Gilead use nicotine, and some are taking medications for tobacco cessation. So these might be like nicotine gum, lozenges, or like oral meds like Chantix. Like we talked about with med administration, some people are on inhalers or nebulizers. These are generally people who have asthma or COPD. So these often have a medication called albuterol, which helps open up your airway, or steroid medications, which decrease the inflammation in your airway. So these might be inhalers or nebulizers, which is like a little mist machine that you hold on your mouth. And in terms of diabetes, so some clients may have type 1 or type 2 diabetes. Type 1 is when your body no longer makes insulin. This is traditionally the one that was like more earlier onset in life, and someone needs to be on insulin forever for this. For type 2 diabetes, this is like you still make insulin, but it doesn't really work anymore. And this is more common in clients because this is what can happen from those metabolic side effects. So these are generally treated first with like pills like metformin, but sometimes the pills don't work fully to control it. And then someone might be also on insulin. And in clients with diabetes, they'll need to monitor their blood sugar levels generally. So these are some general guidelines for high and low blood sugar. So hypoglycemia, like under 60 is pretty low, or over 180 is considered high. But these are super rough estimates because blood sugar is a very individualized thing. So what's normal for one client might not be normal for another. So if you are unsure, you'll definitely want, and if you're caring for a client with diabetes, you'll want to definitely check in the MAR to see, because it might say, if this client's blood sugar is over 200, call their PCP, or if it's over 500, call 911. So it's good to kind of have those in your mind when you're caring for them. And these are some symptoms of high and low blood sugar. So low blood sugar, people might be irritable, hungry, nauseous, sweaty, just not really feeling right. And hyperglycemia, which is the high blood sugar, people might have be super thirsty, peeing a lot. They might have a headache, nausea, vomiting, or visual changes. So these are just, again, good to kind of keep in mind that these can indicate something if you have clients with diabetes, because while they should be checking their blood sugar regularly, sometimes people aren't, or they're like refusing to do that. So knowing that these could be sort of emergency type signs is helpful as well. Okay, that's all we have here. Does anybody have any questions for us?
Yes. Are there cheat sheets in the programs for if administrative staff have to work in a clinical program for a period of time?
Yeah, so I think the plan is that we're gonna hopefully have you all like come to a program for like a day, so you get to see like basically our whole hope is that you'll like come like around a med pass. So say you came from like 11 to 1, you'd see all the med passes that happen in that time, and then you do a few, so you sort of like have an idea of how it works. And then I will say that everything is pretty documented, and like there's documentation like everywhere about how to do things, and like in the MARs there's often like on the front page like how to do this, like just like an updated like 1 2 3 4. I think also, I don't know how super likely it would be for you to be there alone for the first time, right? Like I'm assuming, I think our assumption a little bit is that someone else will be there at least for like the first day, to sort of guide you through what's going on. That's I think the idea.
I'm with Joe. This is like, there needs to be more. I think it was very quick, so
Yeah,
therefore
I'm kind of thinking that there needs to be a slightly different approach to how we do this. And For Allie and Maya, it's definitely not directed at you because I think that you both did a great job on this presentation. But I do think that there are some other people in clinical management that may need to help us out. I think that we're going to need some cheat sheets on the 5 rights on how to use an MAR.
Right.
I mean, I know a lot of the technical terms that were used for different issues that a person may have. I'm never going to remember those. I won't, a lot of it, I just won't. And doing it for a day or, you know, and learning it, I think is great. Hands-on is great. And, you know, maybe the first day that I work in a program, I won't be alone, but the second day I will, and I'm still not going to learn it all. And I will not learn it all. That just won't happen. I'm not making a career change. I'm assisting, I'm helping, I'm stepping up and stepping in. So I can't take this all in. I'm going to need some assistance at the program, visually, something to read, something quick. And I know that we have a lot of documentation in the programs for how to do things, because we do document things very well. And Gilead does have a lot of procedures for a good purpose. But I think that administratively, we're going to need something else to help us through this than just having documentation everywhere.
Right. And I think I'm not 100%, but I would think that the staff that pass out meds get med trained, and it doesn't happen on a quick tutorial on what we got. And yes, I agree with Joe. It was really good, but we're not going to remember this 33-page document of everything that was described in there.
So what we do with the ACT team is, and my plan, I can speak for the ACT team, is to print out this PowerPoint and make a binder. We've already got a binder of the old information, and that's readily available for everyone. And I understand the pressure and the stress of you know, stepping up versus filling in. I get it. And the hope would be that nursing and AOC are widely available by phone with any questions you might have whatsoever. And then this PowerPoint can be readily available in a binder in case you have a question about the next step. I can't see any reason why we wouldn't post maybe a page on the 5 rights. We have done that in the past at ACT. I can't see why we can't post that. For example, in the ACT building, we're at the resource center, so we're in a whole different world now. We're not even using our nursing office, but I can't see why we wouldn't print out a page of the 5 rights and put it on the front gate of where you're going in to look for medications.
But
And then if there are any other suggestions for things that you might find comforting and helpful, by all means.
I just think that all of the side effects, what to look for, what you should call 911, what do you call AOC for? I think it's a lot to take in. And
It is.
again, I'm going back with Joe. I would hope that we weren't in the programs alone. There would be some kind of clinical staff that's there that, you know, yes, by all means we can help. But honestly, I don't feel comfortable being responsible for passing out something that could have a reaction with some other medication.
Yeah, I get it.
And then we don't, you know, ultimately, you know, a lot of us, we know the clients, but not like that, not their medications, not when they're getting them, what to look for, what not to look for.
I think also different programs are set, like, right, like at GAP we have sort of this quick how-to in the front of the MAR, and it's sort of like, if you forget any step or you freeze, like, don't worry, go there, and it says specifically when to call AOC, right? Like, I think in different group homes and programs, they've like come up with their system for sort of like how to streamline that process. Like, happy to send that out. I think that can be helpful. I think when we are talking about side effects and things, I think what we're really talking about, and I get that this will be hard, is just like noticing if someone's different than their baseline. I think like that's really on a day-to-day, that's what's happening. And hopefully like a nurse, like a nurse will still be coming in weekly to sort of check in on folks and things like that. And directors will still be coming in weekly to check in on folks because they know baseline.
Yeah.
Just-
And I would be available by phone if nothing else for my 4 places that I have.
And also in the MAR, under every med, it says side effects, like in the MAR. Generally, like clients come and tell you if there's something weird going on, and then you sort of just pass it on to a program director or manager.
I think.
Yeah, I just wanted to jump in. I think that's really good feedback, Stacy and Joe. And I think, I like the idea of maybe creating a cheat sheet or something. I think about like if I had just received, so obviously I come from, the clinical background. So a lot of this, is repetitive for me, but, I'm thinking if I just sat through a 60-minute presentation on any number of things that like Joe, you do on a daily basis around, IT details, my head would probably be spinning right now. So, if we could create some cheat sheets that pull out like the most important, so the 5 rights, these are the things we have to verify. I mean, that can be really spelled out in a way that you can walk through it in a systematic way and make sure, okay, I've got the right person, check. I've got the right medication, check, and because at the end of the day, it's great if we catch medication errors from the pharmacy, and we should be doing that. That's part of the redundancy of the process. And it's great if we, notice side effects, that's important, but we have to make sure we're supervising those 5 rights. So there's certain pieces I think that could pulled out to simplify a little bit that might relieve some anxiety, that here are the things I really have to make sure I'm doing. And then, yeah, here's maybe some of the top side effects to watch for. So like a 3 or 4 page kind of quick cheat sheet. I don't know who has the ability to pull something like that together, but I think that could be very, very helpful in the event that we did have to call on admin staff to work in programs.
Yeah, and like you're not expected to be like a clinician or be like, like recognizing all these things all the time. Like a lot of it is just like background knowledge that can be like interesting to know if you're there all the time, but like it's in no way like required for you to like memorize all the medical stuff to safely give meds. And there are like so many checks and balances, and like it is up to like clinicians and nurses and like providers who are like prescribing those meds also for the safety of them. Like you are not the person who's like deciding if a medication is safe to give all the time. It's just like we're giving you a lot of information, which is overwhelming, but there are like a lot of people who are like working hard to make sure that everything is safe for you and that you can call if you ever have a question.
Yeah, I think that's really helpful. And I liked the slide. I think you were presenting it, Maya, around kind of like, okay, like here's practically what it is. So, person comes into the office, maybe there's a way to turn that into a 1-page, literally like, step-by-step how to, identify the client, have them come into the office, 1 person at a time, just a really that slide kind of pulled into a step-by-step that someone can pull that out and sort of look at it and do one thing at a time. Obviously, it's going to be slower than someone who does this every day, but just making sure that, okay, if I do everything on this list and I follow the 5 rights, I do everything outlined here, then I'm doing my job and I've completed what needs to be done. Maybe something like that would be helpful.
I think also it's easier when you're in the program, like we're trying to teach you how to ride a bike, but there's no bikes. So it's easier if you're actually like looking at an MAR or like watching, if you like observe a client getting meds, like it all seems kind of like hypothetical when you're talking about it in this setting. But like actually seeing the process can be a little bit easier, I think.
And I
think
just
it would
have one
be-
other question. I know that you were very firm on no abbreviations just to avoid the errors, but when the doctors write these prescriptions, they use these abbreviations, but did you say that they're transferred into the record correctly without the abbreviations?
Yeah. We
Okay.
don't like basically in the sections where it says how someone's taking a med, it's going to say like take 1 tab by mouth this
Okay.
many times a day. And that's to avoid error. So yeah. And if you ever have a question about an abbreviation, I think most MARs have a cheat sheet in them. And if they don't, like, ask, because I think that's often what happens is people ask.
I gotta
And
say,
you're also
oh, go
not
ahead.
writing, you're also not, like, it's not every single day that you're writing a new medication in the MAR, like that generally everything is printed from the pharmacy unless someone's medication like switches in the middle of the month or they like get an antibiotic or something like that. So if you aren't like comfortable writing that, like that's something that you can like check in with someone about, definitely, because that's not like something you'll be doing constantly.
I've been working for Gilead for 15 years. Never once have I ever heard it mentioned ever that we don't use abbreviations. Never knew it. Just learned it. I was amazed.
I think it's trying to be like phased out. I think there are things that are probably used, but then you're like, does this mean teaspoon or tablespoon? I don't actually remember. And then
It would be helpful to have a sample MAR that with instructions, and also maybe a picture of the back of those disc bills, because it really does spell it out with the client's name and all the medication. And if people see that, they might be a little more reassured that it's real clearly spelled out from the disc bill itself.
Great. I will try, we'll bring that back to the nurses and we'll try to create a cheat sheet, sort of like a one-page how-to. And we'll see how we can figure, I think often we don't include pictures because they have HPI on them, or not HPI, like personal identification information. So, but I think maybe we can come up with like a tester just so you guys can see what it looks like that like has like some, like a blank name. Yeah, and I think we're going to try to get you all, I think, into the programs to sort of see what's going on. And I think if folks want a second day, I think that's totally great. And like, we can sort of do it until people feel comfortable. Yeah, great. Thank you all so much for coming. And I hope you guys have a good new year.
Thank you.
Thanks, guys. Great job.
Okay, Allie, stop recording.